Okay, it's 4:01. Let's start, Dr. Lewis. So welcome everybody to the fourth and final session in the Department of Medicine EDI Summer Series. I'm very pleased today to welcome Dr. Lewis to chat with us. Dr. Lewis, I will introduce you here for a second and let you run the show right after that. Dr. Lewis is a professor of emergency medicine and radiology at Thomas Jefferson University Hospital in Philadelphia. She directs the point of care ultrasound section, publishes and speaks on equity, health design, point of ultrasound, med ed, global health, and navigating the workplace, including leadership and mentorship. Dr. Lewis has led point of care ultrasound education courses regionally, nationally, and internationally. She graduated from Brown University with a degree in sociology and racial ethnic studies, then attended University of Pennsylvania School of Medicine and spent some time at NIH, as well as graduated from residency at Harvard affiliated emergency medicine residency program in Boston. She graduated in the first emergency ultrasound fellowship class at Mount Sinai St. Luke's Roosevelt Hospital Center in New York. She was the fellowship director and chief of emergency ultrasound section there, and then followed up with the program at the University of Colorado. She continues to publish, speak, and is obviously committed to creating a safe, equitable, and dignified work environment in healthcare. She's the creator and the host of the Visible Voices podcast, covering topics of healthcare, equity, and current trends. Her work has been published in HBR, Fast Company, and Slate, among others, and you can learn all about it in the website, which I will include there, and I will also include in the chat her Twitter handle. Welcome, Dr. Lewis. We are so pleased to have you, and we're so looking forward to our conversation today.
Good afternoon, everybody. Thank you, Silk. And just out of curiosity, how many audience members have joined us?
There are currently about 36 individuals here.
Amazing. Amazing. Mm-hmm. Hi, everybody. In this age of Zoom, you realize that I can't see you, even though you can see me. So as Silk shared, my name is Resa Lewis. I'm speaking to you today from Philadelphia, Pennsylvania. And I'm going to slide share in a moment. And just let me say that the current chair of emergency medicine at Indiana, Peter Pang, was my classmate in Boston, and he is a friend. And I know the ultrasound faculty at Indiana because as is true of most communities, we all know each other, and we all were just at a conference in Madison, Wisconsin. Thanks so much. I'm going to share the screen now. Let's make sure. Okay, so I'm going to start with a story. When I finished residency in Boston, the year was 2001. And I was making a decision about whether or not to pursue academic medicine versus the community. So I spent about 9 months working at a community hospital. Now, that community hospital in Boston is called South Shore Hospital. And maybe some of you are familiar with South Shore, but it's an amazing, high quality clinical environment. It's a lot of people that have trained in Boston, but have decided to, not work in the academic centers. So I heard about an opening right after I finished residency to work there, and I decided to interview. And when the chair interviewed me, he said, Resa, there are 3 reasons why I don't want to hire you. Number 1, you just finished residency, and I don't really like to hire people right out of residency. I like to have them a little bit of clinical experience. Number 2, you're from the Harvard program, and well, that's a less established program in the city. BMC, Boston Medical Center, that's much more established, and that's where I usually hire people from. And finally, he said, and I don't want to hire you because you're a woman. And I don't have really good luck with women. They tend to get pregnant. And I didn't react externally. I kind of reacted internally. And I thought, that's really interesting that he just said that. I think he is saying what many people think, but they just don't have maybe the guts to say it aloud and say it to the person. And also I thought, and remember, this was 2001. We're not there yet. We're not where we should be. So using health design thinking to create gender equitable workspaces. So why Resa? Well, you heard a little bit about me, a little bit about my bio. You heard a little story, and boy, do I have lots and lots of stories. But more than that, I think I was reached out to by Silk because of this piece. In 2020, we published, Is Academic Medicine Making Mid-Career Women Physicians Invisible? Now, the background to this piece is I had been speaking with friends, men and women in medicine. And what I had noticed is that women were sort of disappearing. They were either literally or figuratively being made invisible. And in fact, I was noticing that as I went along and continued on my academic path, many of my women friends and women colleagues were going part-time, going into the community, leaving academic medicine. They were starting new education companies. They were working in real estate, but basically women were being invisible. And what we thought was, although we were hearing that all the reasons were, well, it was their choice, well, they have children at home, well, they have elderly parents, well, they really just, wanted to do, we knew there was more to it. It wasn't just that women were making this decision voluntarily. So I mentioned health design thinking. Some of you are like, what is health design thinking? Why is Resa bringing this up? And what does this have to do with gender equity in the workplace? Well, I recently had an episode of the podcast, a guest from Chicago. She's a designer and she's the founder of IA Collaborative, which is an innovation and design consultancy based in Chicago. And she said something that really struck me. You have to live the problem to design the solution. You have to live the problem to design the solution. So men colleagues, men friends that have joined the talk, they're like, all right, see, exit stays right. That's why this doesn't involve me and this doesn't pertain to me. And this is why I don't need to solve this problem. But I want to say, au contraire, we actually do need you and we do want you to be part of the problem and part of the solution. So maybe you don't have the lived experience, but there are ways that you can iterate and create circumstances where you do live the experience, you live the question, you live the problem, and in doing so, you help lead and design the solution. So this diagram is from a book called Health Design Thinking. So this is a book by Ellen Lupton, who's a graphic designer based in Baltimore, and Bon Ku. Bon Ku is an emergency physician and health designer with me in Philadelphia at Thomas Jefferson. And health design thinking is a framework. It's a framework for addressing virtually any question, any problem, any workflow, any device that you're trying to make better in the workplace, specifically in the healthcare workplace. It's even healthcare and health design thinking is applied to the built environment, like creating better spaces for patient care, better outpatient clinics, better telehealth setups, et cetera. So the concept of health design thinking is these three things that you see: observe, imagine, make. So first of all, you start off with your question or your problem that you're looking to solve, and you apply and approach this problem, this question, with a very open mindset, growth mindset, curious mindset. And then you go into a brainstorming, the imagine. Imagine the solution. Imagine different solutions. Imagine different ways that this problem, this question affects different people. Specifically, how does it affect the end user? The end user is the patient. The end user is perhaps a caretaker. In the case of gender equity in the workplace, the end user is us. It is clinicians. So thinking about ways to create safer, better gender equitable environments. Once you do this process back and forth of asking questions, approaching things curiously, you iterate, you reiterate, and it's a very arduous process that you actually go back and forth, and then you come to a point of solutions, action items, protocols, policies, that because of that iteration and that curious health design thinking framework, you actually come out with things that perhaps are sustainable and perhaps can create culture change. Now, one thing I want to ask is, feel free, I can't tell, but perhaps you have your phone or perhaps you have your type board ready so that you can do screenshots, because I'm going to be pointing to a bunch of articles and a bunch of literature, and I want you to feel free to take a screenshot so that you can refer to it and go back and do some reading after our talk today. So why do we want women on our team? Why do we care? Why do we care if they go away? Why do we care if they become invisible? Well, hopefully you've seen and you know why we want women on our team. Number one, diverse teams are smarter and women are excellent clinicians, in case you weren't aware, in case you didn't know. So Harvard Business Review 2016, Why Diverse Teams Are Smarter. This was an article that was based off of the 2015 McKinsey report. And the summary of the authors from this article, what they had to say is that diverse teams focus more on facts. They do more accurate group thinking together. They're more innovative. There are higher retention rates. You don't lose team members. There's overall better morale, and there's higher return on investment. And I want to sort of star asterisk the higher return on investment, because for leaders, for people who may not feel the importance of diverse teams in their hearts or may not feel it in their brains, at the bottom line, when it comes to the finances of a team, of a department, of an institution, people do pay attention to the bottom line. So this is that 2015 McKinsey report entitled Diversity Matters. And the summary of this report is they looked at companies in the top quartile. And they looked at companies both in the United States and in Mexico. And the companies in the top quartile for ethnic and racial diversity in management were 35% more likely to have financial returns above the industry mean. Those in the top quartile for gender diversity were 15% more likely to have returns above the industry mean. In other words, companies that do poorly in creating respectful environments for women and minorities have lower than average financial returns. A lack of diversity hurts the bottom line. So if you're having a hard time reasoning with someone, if you're having a hard time penetrating their thought processes, you can basically appeal to the bottom line and the finances. Now, I want to make a caveat. Most of this talk focuses on gender, and this is not at all to minimize the importance of racial ethnic groups and other underrepresented groups in medicine. What I will say is intersectionality, being a member of more than one marginalized group, more than one underrepresented group in medicine, actually has a compounding effect of many of the things that we're going to discuss. Okay, women are excellent clinicians. So that has sometimes been brought up as one of the reasons why there isn't equity in the workplace, but there's been quite a bit of literature. And I will say that as I went on my journey from being an emergency physician, focusing on point of care ultrasound to moving more into the equity space, I was surprised to see that a lot of my notions, a lot of my thoughts about the way things were and what I saw around me are actually supported in the literature and supported by the data. So this is a great study published in JAMA 2017 by Anupam Jena et al. Anupam came on the podcast and we talked about this particular study. Ashish Jha has also been on the podcast. The work that he was doing then is very different than the work that he's doing now in the White House. So the title of this paper, Comparison of Hospital Mortality and Readmission Rates for Medication Patients Treated by Male versus Female Physicians. So Anupam said they were trying to find, like, what's a randomized way that you're not going to be able to guess if a patient is going to be taken care of by a woman, by a man. And they said, let's look at hospitalist medicine because they do shifts and you never know who's on, who's off, and these aren't the hospitalist specific patients. So they used Medicare data sets and they analyzed patients and they looked specifically at 30-day mortality rates and readmission rates. These were either treated by female internists or male internists. And what they found is the patients treated by women, female internists, had lower mortality and lower readmission rates as compared to those cared for by male internists. The reasoning was thought to be that women are more likely to adhere to clinical guidelines and follow evidence-based practice. Well, what about surgeons? Do women surgeons have more surgical complications? Well, no. In 2017, BMJ, this article came out, comparison of postoperative outcomes among patients treated by, I'm just moving my box so I can see, by male and female surgeons, a population-based matched cohort study. So the primary outcome also looked at death, readmission, and complications. They looked and studied over 1 million patients who had one of 20 surgical procedures over an 8-year period of time, and this took place in Canada. What they found is that patients treated by women surgeons had lower odds of death at 30 days, and there was no difference in length of stay, complications, or readmission rates. Finally, being an emergency physician, I had to I had to look at emergency medicine. This is a really kind of upsetting and interesting study published in 2018. Patient-physician gender concordance and increased mortality among female heart attack patients. So this took place in emergency departments in Florida over a 9-year period. And what they found was, it's not funny, there's higher mortality rates among women patients presenting with acute MI when treated by male physicians. Male patients and female patients experienced better outcomes when they were treated by women physicians, suggesting that there's a unique challenge that arises when men physicians take care of women patients. And hopefully in internal medicine, you've read the literature about women and heart disease, women and heart attacks, and the extent to which they're taken seriously. Finally, another finding of the study, it was thought that male physicians with more exposure to female patients when there were women physicians on the team working with them or leading them had more success in treating female patients. In other words, being exposed to and working with women physician colleagues helped you provide better patient care for women physicians. Okay, so what happens to women in medicine? What happened? Hopefully you like the icon, you recognize this icon. This is a pipe and this is a leaky pipe. And you're probably familiar with the concept of the leaky pipeline. Women make up 50% of medical student classes these days, matriculating 50%. However, in the physician workforce, 36%. So that's just one indicator of something that happens, of how the numbers don't stay. And I told you what I observed about my mid-career colleagues and how essentially all the women from my 4 years of residency training are no longer in academic medicine. This diagram comes from a website. The website is CWAMS. And this is the Center for Women in Academic Medicine and Science. And CWAMS is trying to change the face of academic medicine and help promote, protect, and maintain women in academic medicine. So it's a bit of a busy diagram, but let's walk through it. The bottom stripe, purple, is medical school. The middle stripe gray is training, and the upper stripe green is faculty. And so let's just look at the bottom one. You can see that the applicants, matriculants, and graduates, there's a little bit of a loss from 51% women, 12% underrepresented in medicine women, to graduating med school, 48% overall, 10% URIM. Let's go up to the faculty pipe. Instructors, women, plenty of women. In fact, the majority of instructors in academic medicine are women, 59%. 8% are underrepresented in medicine women. And then let's look all the way up to full professor. You can see we've gone from 59% to only 26%. Of full professors in academic medicine in the United States, all specialties, 26% are women, 2% are underrepresented in medicine women. And interestingly, not interestingly, these numbers have not changed much over time, over the last 20 to 25 years. Based on the CWAMS website and the video, if you were to hear Jenny Mladenovic speak, it's estimated that at these rates, we're not going to reach equity until another 50 years, 50. So in 2018, 2019, the AAMC put out a report. The report is entitled "The State of Women in Academic Medicine, Exploring Pathways to Equity." Now, they had put out a similar report, 2014 to 2015. There's a lot of writing here, but my two red arrows are pointing to the two that I'd like you to digest. Among full-time women faculty, the proportion of women from an underrepresented in medicine race or ethnicity group was 12% in 2009, 13% in 2018. That's only a 1% change, a delta. I know you can do the math. The greatest proportions of underrepresented in medicine women faculty were at the assistant professor rank. And the last point, while there's been a steady rise in the number of women department chairs over the last 10 years, women still make up only 18% of all department chairs. And that's an example of a number that hasn't changed over the last 25 years. So on the website, the AAMC, you can download this report for free. There are a lot of good slides and documents that you're allowed to reproduce as long as it's for educational purposes. And just what I've done in red is to really highlight. So the percent of women chairs, if you look all the way at the bottom of the arrow, 19%. And I highlighted for you and for me, emergency medicine, 11%, internal medicine, we'll call it 18%. Another interesting diagram, percentage of medical school deans by gender. You can see all the way on the left is the year 2009, all the way on the right is 2018. On the y-axis is the percentage of deans, and women have gone from 12% to 18% over this time period. Full-time women, faculty as a percentage of each rank, and we know this, we kind of mentioned this already. If you look at the top line, which is purple, instructor, 58% of instructors in 2018 were women, 25% were full professors. So what causes what happens to women in medicine? And what causes what happens to women in medicine? You can read that sentence a few ways, that questions. And what I asked Silk is I asked her to please take a look. If you can type into the chat box, type into the response area, what causes what happens to women in medicine? If you can kind of put some reasons about why you think we don't have the equity we seek and the numbers sort of haven't changed much over time. I'll give you 30 to 60 seconds.
They're coming in. So some say we may be our own worst enemies. Second one says home life. Number 3 says systems change slowly. Another one says unfavorable environments for balancing competing demands on women's time.
Mm-hmm.
The second shift at home. You can all send a couple more, okay? The general state of medicine, fear of losing position status, asked to do a lot of service work resulting in burnout and not allowing them to focus on what needs to be done for promotion. Not thinking we're good enough. Any more coming in? Those in power may not want changes to occur. Overwork is rewarded. Are those enough, Dr. Lewis?
Oh, it's more than enough. I think it's great. And
Okay.
I've noticed a bit of a pattern over time. We went from maybe what would be considered safer answers to more honest answers. And I just want to state that I completely get it in terms of being able to say or write exactly why. And so I understand. And I also want to thank you, Silk, for doing the land acknowledgement. I really appreciate that and do value its importance. So I'm glad to see that. I've not participated in a Zoom lecture where that has been put in as part of the chat. So thank you. Okay, so let's get into some of these causes. This is not going to be every single thing that we can think of, but it's definitely going to cover some. Moreover, and I wanted to use the word moreover there, I'm going to, show some data, show some of the publications that support our notion of what causes and what happens to women in medicine. So no one mentioned this, but we all know about this. There's the gender pay equity gap, okay? Men make more than women for the same exact job when all factors are controlled for. And it's across every specialty essentially. And again, there's a compounding effect. If you are intersectional in terms of your identity, then it's even more of a gender pay gap. So this is a paper from JAMA 2016. Sex differences in physician salary in US public medical schools. This actually was another paper that we talked about with Anupam Jena. He's one of the authors. So they looked at over 10,000 men and women physicians across 24 US medical schools, and they found significant sex differences in salary, even when they accounted for factors such as age, experience, specialty, faculty rank, and measures of research productivity and clinical revenue. And you're like, okay, that's great, Resa, can you orient me to these graphs? So on the left is men, and on the right is women. On the x-axis is salary, annual salary in hundreds of thousands of dollars, and on the left is percentage of physicians. And again, on the right, the lighter blue is women. And what you can see is that the bar graph is skewed to the left, and a higher percentage of women make less salary. It's not just physicians. I don't know if any of you have done a deep dive into this literature, but it's not just physicians, it's nurses too, it's dentists, it's essentially all of healthcare. So this is an amazingly impressive graph because we know that nursing is essentially 90% women. This 2015 JAMA study entitled Salary Differences Between Male and Female Registered Nurses in the United States, they looked at two different surveys. Both showed that unadjusted male salaries were higher than female salaries during every single year. So x-axis, we have the year, y-axis, we have annual salary. Male nurses out-earned female nurses across settings, specialties, and positions with no narrowing of the gap over time. So we have orange women nurses and green men nurses. It's pretty impressive, Okay, so salary gap. Next, I want to introduce you, if you haven't been introduced, to this concept of Jennifer Jean Janet. So when we were writing that mid-career invisibility paper, it took a few iterations, just like most academic publications: submit, resubmit, fix, resubmit. And one of the peer reviewers was very generous and said, you really want to include these two editorials by Molly Carnes, who is based in Wisconsin. She co-authored an editorial in 2007, and then she co-authored another editorial in 2014. The 2007 editorial was called Jennifer Fever in Academic Medicine. The 2014 follow-up editorial was entitled Stuck in the Outgroup, Jennifer Can't Grow Up, Jane's Invisible, and Janet's Over the Hill. So here's the concept. There was a book written by someone named Barbara Gordon. The book was not about medicine, but basically the title of the book was Jennifer Fever. And she basically talked about in the setting of cis hetero men marrying women that often first wives were age concordant, but then when they divorced, their second wives were often much younger. And she kind of provided reasons for this. And she was the one that came up with this concept of Jennifer Fever. So when Carnes et al. Were describing this, they were talking about this concept in medicine where male physicians were very interested to help, to mentor, to acknowledge, to invite younger women, early career women, to participate in learning, in research, and sort of in promoting them. However, something happened, and this something that happened was something that we were trying to describe in our mid-career invisibility piece. So the follow-up editorial, Jennifer Can't Grow Up, Jane's Invisible, Janet's Over the Hill, this is sort of representative of three different career phases of a woman professional. Specifically, Jennifer's early career, Jane is mid-career, and Janet is late career. And it's this concept, I was sort of really blown away that sort of this concept of invisibility was described as such. And there wasn't a lot of data, but it was sort of this phenomenon that was occurring that had been appreciated. So relatedly, we published this piece in Slate magazine. Medicine has a status anxiety problem. The male-dominated and intensely hierarchical field has allowed professional tantrums to feel normal. And the concept, going back to the Jennifer Fever and Jennifer Can't Grow Up and Jane's Invisible, is that over time, women who initially need a lot of help, perhaps are more innocent, less competent, less confident, once they sort of become more confident, more competent, and they're more of a threat, they're more competition, that's not actually as welcomed. And they, men in medicine feel threatened by their competence and by their mid-career age and stage and accomplishments. Many of you sort of refer to this. This is the motherhood penalty, and that this is often pointed to as perhaps why. Now, this has been studied quite extensively as well. 2017 JAMA piece, Perceived Discrimination Experienced by Physician Mothers and Desired Workplace Changes. So this was a survey performed on Physician Women's Facebook group, I believe. And the middle bar, the middle blue, represents women who have experienced these examples of maternal discrimination. My pay or benefits were not equivalent to my peers. I was not fairly considered for a promotion or senior management. I was treated with disrespect by nursing or other support staff. I was held to a higher standard of performance than my peers. I was not included in administrative decision making. And this came on my radar as I sort of went from being early career to mid career. I started having friends tell me stories. And I think one of the ones that really knocked me off my feet was a friend was out on the West Coast, emergency physician, and she was going out on maternity leave, but she was in her third trimester. And although she was no longer having shifts, she wasn't due for at least 1 to 2 months. And what she noticed was she was started to be left off emails where she was a committee member, not just a committee member, but she was actually leading the committee. And so when she asked, why did you stop emailing me? Why did I stop getting the notes? They're like, oh, well, you're pregnant. Now she said to me, Resa, like, I can read, I can write, I can walk, I can still participate in committees. And sort of, she was just sort of left off. One of the things that I was, that is a very common joke is, when people go out on family leave, and I'll say specifically maternity leave, they came back and people were like, oh, how was your vacation? And sort of this sort of sense of lack of respect, and this, like, it's a joke, and that it's sort of women can be replaceable, is something that sort of has been considered for a long time. And quite honestly, I think decisions are made on behalf of women that they're not interested in maintaining their leadership positions. They're not ambitious. Oh, they have children now at home. My experience is often women aren't asked. These decisions are made on their behalf. So those of you who are HBR readers probably, hopefully, saw this article that just came out last week, 3 workplace biases that derail mid-career women. And lo and behold, look, the motherhood penalty. One of the most common is that these women, who are often actively parenting, the perception is that they are less committed to their careers than their male peers. This assumption has demonstrably harmful effects. Studies have found that it leads to discrimination against women when it comes to hiring, promotion, and pay. So I really wish that if this were a live presentation, I could see sort of reactions of everybody, like, like agree, disagree, aha, smiling, like, thank goodness I see this. Some people are like, that can't be true. But the fact is, if you sense that something is happening in your environment, or you've seen certain things, you've noticed certain patterns, there's probably written literature to support it. Okay. The NASEM report. In 2018, NASEM, the National Academies of Science, Engineering, Medicine, and Mathematics, put out a report. They were evaluating the state of sexual harassment in the STEM fields. Lo and behold, medicine was the absolute worst. And what you can see by this diagram that comes from the NASEM report is they use a very broad-based definition of sexual harassment. And you can read discriminatory behaviors, sex and gender discrimination, gender harassment, sexual coercion, unwanted sexual attention. And note, I know nobody wrote this in the chat box, but there is no question that sexual harassment, discrimination, bullying, gaslighting, many terms that kind of fall in this umbrella, play a role in why we don't quite have gender equity in the workplace. So the refreshing thing about the definition, the broad-based definition, is that the NASEM basically says all of this is sexual harassment. All are corrosive to work. All are corrosive to the well-being of women. And when we say corrosive to work, corrosive to well-being, difficulty concentrating, anxiety, depression, post-traumatic stress, diabetes, hypertension, heart attack, strokes, basically physically and mentally, it takes a toll. So their words, there's no justification for ignoring perceived less egregious forms. It's not like one form is less egregious than the other. And we hear this also in the workplace. Well, it was just a joke versus, oh, he touched you, almost like there's a scale and there's a range of severity. And, the refreshing part of this report is it put words to things that we know are happening in the workplace and sort of doesn't say that there's a range of behaviors. Some are more okay than others. They're all corrosive and they're all detrimental to the work environment. Lo and behold, we published a piece on this too. So last month, we came out with this piece in Harvard Business Review, Stopped Protecting Good Guys. Basically, the premise of this is we defined this concept of the good guy defense. We define The good guy defense as minimizing, excusing, or deflecting the sexist or harassing behavior of a man by appealing to the utility of this commonly used phrase, oh, he's a good guy, or he didn't mean it, he's a good guy. I know he did that, but well, he's a good guy. And in calling someone a good guy as an explain away defense, men and medical institutions are offering an endorsement of the offender's moral character, suggesting that his innocence and signaling an allegiance to him. The good guy defense serves two salient functions: to gaslight women and to enable the offender. So my co-authors and I wrote this piece because we see this defense used quite often. And it is this explain away and sort of makes it very difficult to hold someone accountable. But also when you're someone that's had this defense used against you or used when you bring something to someone's attention, it totally is deflating. And for what it's worth, men and women, my lawyer friends, my education friends, my business friends, my advertising friends, this concept of the good guy and the good guy defense is universal across fields. Going back to the AAMC 2018 to 2019 report, this is actually a diagram and illustration that supports a little bit of the harassment and discrimination, basically saying that the top four fields, anesthesia, emergency medicine, orthopedic surgery, are the fields with the largest percentages of women reporting disrespect. And notably, they said that 2 of these 4 are the ones with the smallest percentage of women in those fields. This didn't come up, although someone did say this, that sort of like we're our own worst enemies. Women aren't likable. So we know we're likable. We're likable. We're good kids. Why wouldn't someone like us? Well, it turns out that in some of these institutions, in medical institutions and academic medicine institutions, women and women traits aren't considered as likable. And this is a very interesting classic case report called Heidi versus Howard. And this is a case that was discussed in Columbia Business School. And the researchers divided the class up into 2 groups. Group 1 got a case study of an entrepreneur named Heidi. It detailed her outgoing personality and her very powerful network. Group 2 got the same exact profile, but instead of being named Heidi, the person was named Howard. The groups then gave their impression of the entrepreneur. Second paragraph. The students respected Heidi and Howard equally, but gave Howard greater likability scores. They found Howard more appealing than Heidi, even though it was the same exact story. The same data created different impressions depending on which gender was cited. Heidi was seen as selfish, Howard was seen as appealing. The teams wanted to work for Howard, they didn't want to work for Heidi. Now, some of you mentioned some of these other reasons that sort of are contribute to promotion, contribute to leadership. This is evaluations. There's plenty of data to support that women don't get evaluated equally, and they often get worse evaluations than men. Letters of reference. There's a lot of literature on letters of reference and how letters of reference for women are often shorter. And rather than actually commenting on competence and accomplishments, they'll often talk about likability. They'll talk about personality. Sometimes they even talk about appearance. Authorship. First authorship. We all know that first authorship and last authorship, depending on the institution, are the most important. Women get fewer opportunities and or aren't put in positions to have more opportunities to be first authors. Research and research dollars. Awards. Who's put up for awards? How do you get those awards? And finally, lectureships and speaking opportunities, because again, all of these contribute to being recognized as a leader, as a subject matter expert, and for being promoted. And I hope you're aware of this. You know, what happens is, just sidebar, I didn't know there was so much literature that sort of supported this. If you haven't noticed, start noticing. It's common in terms of leaders and speaking opportunities that women will be introduced by their first name, but men will be introduced by the term, name, phrase, doctor. And this just happened at this conference that I attended in Madison, Wisconsin. Some of the young faculty, they were there, noted that the women were getting introduced by their first names and the men were being introduced as doctor. Back to research, women receive 25% of the NIH grants and 21% of total funding. The NIH grants awarded to women are 80% of the grant funding amount awarded to men. And the NIH has taken a bit of responsibility regarding this and started to do things to rectify the equity around granting funds and granting the amount of these funds. So what can we do? Remember our health design thinking. Remember that we have to be curious about what our question is. Be curious about what our problem is. Brainstorm about what really is the problem. Try to come up with solutions, iterate, reiterate, have the end user in mind, and then come up with some solutions. I think I'm going to outline about 4 or 5 things that we can do. Before we go into those, I want to remind you that the success of an intervention is undermined where it relies on the additional labor of those it is intending to support. I'm going to read that one more time for those of you like, what? What's Resa saying? The success of an intervention is undermined where it relies on the additional labor of those it is intending to support. So you've heard of the minority tax. We as women have been told to fix ourselves. There are plenty of women's groups that are sort of given the task to fix it, come up with solutions, but that just hasn't worked, and I don't think it's going to work. We need men and we need leaders. We need institutional, department, and other healthcare leaders to believe it in their heart, believe it in their head, that something needs to be done to change the culture. So we talked already about that health design framework that we want to keep in mind. So first is a top-down approach. Traditionally, it's been a bottom-up approach. Again, I mentioned like women are asked to fix the problem that they're recognizing that they're seeing. But a top-down approach really holds the leaders and of these institutions responsible. It also involves men and has men come to the table to help us design, help us fix the culture. I don't know if any of you have heard of something called the Athena SWAN. SWAN is an acronym, like many acronyms we have in medicine, the Athena Scientific Women's Academic Network Charter. This charter started in the UK, and now it's been applied across Europe, Australia, and even here in the United States. The Athena SWAN Charter was established in the UK 2005. The goal was to encourage and recognize the commitment of higher education and research institutions to advancing the careers of women in science. It was expanded to more than science in 2015. So when institutions join the SWAN Charter, they commit to systematically assessing and advancing gender equality through action planning and applying for awards recognizing their success. Now, the key to the Athena SWAN Charter is it's tied to research dollars. Institutions are not awarded the equivalent of NIH research dollars if they don't demonstrate their commitment and their action items regarding gender equity. There's a lot of words here, but what I want to point to is that you're awarded a medal, bronze, silver, and gold. Bronze award requires an assessment of gender equality and the related challenges, as well as a 4-year action plan. You got to show that you're doing something to change the environment, change the culture. Silver recognizes an implementation of a proposed action plan and its measurable impact. Gold, and of course, all the institutions want a gold, recognizes beacons of achievement in gender equality and champions in promoting good practice in the wider community. This top-down effect is something that's recognized by CWAMs, and it's something that's thought to be a viable solution to help change the culture. Next, upstand. Now, again, if we were in person, I would ask for a show of hands. How many of you have heard the term upstand and are familiar with what it means? And if anybody could even give me a definition. So we're all familiar with the term bystand, to be a bystander, but there's been a call for all of us to be upstanders. What exactly is upstanding and where did this come from? Well, Reshma Jagsi, an author, wrote this article in the New England Journal of Medicine, Standing Up Against Gender Bias and Harassment, a Matter of Professional Ethics. And if you're not familiar with Reshma, you should PubMed her. She is a radiation oncologist at the University of Michigan, and she recently was named chair of radiation oncology at Emory. And she has spent much of her career publishing on gender equity. And she really has high impact publications in high impact journals. So in this perspective piece, they talked about, and I thought this was brilliant, that we as health professionals have a moral duty to upstand, to intervene, not stand there as bystanders, but to intervene in response to sexual harassment and gender bias. It's an obligation that should be described in codes of medical professional ethics and supported with institutional training. In other words, they made this brilliant argument that it is our ethical responsibility to upstand when we directly or indirectly witness bias and harassment, which many of us have. And in fact, I always, when someone tells me, said, I've never witnessed it, I've never experienced it, I'm always like, really? Really? However, there's an acknowledgement that sometimes if you're not familiar, if you don't know the literature, like I've been, sharing with you the literature, which by the way, I've just gotten to know over the last few years of being more in the equity space. We can train this. You can be educated to recognize it and to do something in the moment, because we're all human. And when we witness things, it's hard to speak up. It's hard to speak up. It's hard to be like, wait a minute, did that just happen? And it's, our immediate sense of shock often makes us silent and not do anything in the moment. Term limits. Again, if I were with you and could see your hands, I would say, how many of you, with a show of hands, are aware of term limits? Term limits in medicine. Can you name any institutions where chairs have to roll off their chair position? CEOs have to roll off their CEO position. C-suite positions need to roll off, and there are term limits. Well, thank you, Reshma Jagsi, again. She published a perspectives piece with colleagues, Unplugging the Pipeline, a call for term limits in academic medicine. This is in 2019 New England Journal. One factor that has yet to garner attention is the lack of term limits for senior leaders, whose numbers remain disproportionately white and disproportionately male. There is one institution that I'm aware of that does do this, and I think there must be more than one, but there's one that I'm aware of because of friends that I know who work there. The Mayo Clinic. 10 things you may not know about the Mayo Clinic. The Mayo Clinic actually has term limits for its senior leaders. And in fact, of those 10, this was number 4, rotational leadership. Physicians in leadership positions are expected to rotate in their roles on a regular basis. This model allows for continued fresh ideas and allows for experience to be diffused across the system. Administrator and management staff are also given the opportunity to rotate their assignments, leading to high staff retention, as well as cultivating tremendous experience and maintaining well as institutional memory. Seems pretty brilliant, right? Term limits. I'm going to end by, this is a screenshot from the CWAM's webpage, the Center for Women in Academic Medicine and Science. They're the ones that talk about, they have a nice diagram of the pipeline. They talk about the Athena Swan, and this is some of the interventions that they're recommending to keep women in medicine, to keep women in academic medicine and make sure they don't fall through the leak in the pipe. So you can see at the pre-med level, they talk about outreach, test prep, travel grants, moving all the way to the right. Let's look at faculty and leadership, sponsorship, grant writing workshops and reviews, making sure they get promoted, peer support, one-on-one advising, coordination for impact. The outcomes, the intended outcomes, more women as full professors, more women in early leadership roles, finally, more women enter and being retained in executive leadership. I'd like to thank you so much for your attention. I hope you were able to follow. I hope some of this sort of moved you a little bit. I hope you have questions, and please, please know that we really do need institutional leadership, and we need men to be a part of this solution and to be a part of this health design, iteration, and solution forming.
Thank you so much, Dr. Lewis. We have a couple of people raising their hands, and since I know who they are, let me introduce the Department of Medicine Chair, Dr. David Aronoff, and I will allow him to talk. This feels very powerful at this moment, David.
Hey, hello. Can you hear me?
I can hear you.
Can you see me or just hear me?
I just see a picture. I'd love to see you.
Oh, okay. I don't know. I can't turn on my video, but very, very glad for you to give this talk. I was just typing into the chat box. I'll read my own typing. Thank you for this informative and very inspiring talk. We have a lot of work to do, and white males like me who are in leadership position can really play a very, very important part in changing culture and reducing inequities around gender. I really strongly believe in rotating leadership and term limits and really making sure that we're proactive in gender rebalancing. And the top-down approach, I think, is really a way forward. So thank you. And what I would, I wish I could listen to you talk all day, to be fair.
Oh, thank you. I really appreciate that. Check out my podcast. I think you'll dig.
I will.
I'll put a link to the podcast for sure. Okay, now I'm going to mute you, Dr. Aronoff.
Okay.
Anybody else? I must say that, you were you made a comment about seeing individuals' faces. And one of the things that at least we got were some chat comments that I think express some of the outrage. Especially there was one in regards to the nursing data that you provided, especially male nurses, compensation being higher than female nurses, and how enraged this person was about that, given the prevalence of women in that field.
Yeah, it is shocking.
Anybody else here? I promise if I know you, I will let you talk.
These types of talks and these topics make people sometimes hesitant. Maybe I lost them. Maybe they're like, that Resa Lewis, who is she?
They're still all here.
No.
I see it.
Maybe they want to hear a story. Do you want to hear a Resa story? No, I mean,
yes.
I just, I will talk a little bit about, hi, we're here. That's very nice. I'll talk about my own journey, getting comfortable even speaking about these topics, because, people are like, you must have had a very liberal household with parents that were feminists. I was like, actually, no. So a little bit more about me. I actually grew in a very traditional gender rolled environment. And I didn't like it. I didn't, I wanted to be a professional. I wanted to be out in the world, even those weren't necessarily expectations my mother and my father had for me. And I really started observing some of these inequities in medicine, beginning in college as a pre-med. And then, medical school. And then I really think it started hitting me when I saw what was happening to women residents. One of my friends was collecting data on the women resident experience versus the men resident experience, that rates of depression were much higher. We know actually, this is going to extreme, but in terms of death by suicide, rates are different than they are for men in medicine. They're higher for women, but that's sort of jumping to an extreme. But I also say, there were things that happened to me in residency and in early career when I would go to national meetings that I was like, I'm not sure how I'm supposed to feel about this. And some of these were like, for example, this is something that, again, no specific person, no specific institution, but there was a group that would always go to strip clubs. And I'm not here to make any sort of ethical comment or judgment about strip clubs, but I just know that by making that decision that the social outing was going to be strip clubs, not everybody was invited. And in not being invited, I was left wondering, like what networking, what professional opportunities are going to be talked about, or I'm not going to be seen as one of the group. Another thing sort of a little bit along those lines is, it's very common for teams to eat together. And after the overnight shift, teams will go to breakfast. And one colleague at one institution, this is a practice that happened about 15 years ago, so it's not recent, but after night shift, they would go to the local Legs and Eggs special in their city. And I was like, it was a friend of mine that was telling me that he took his team. And I was like, why would you do that? What are you thinking? Oh, everybody does it. It's fun. And I said, not that it matters, but were there any women on the team? Oh yeah, she loved it. And I was like, well, what level? She was an intern. I was like, don't you understand? Like, she's not going to say, she wants to be part of the team and she wants to be, hear the chatter. I said, she's not going to, she's not going to be in a position perhaps to feel comfortable, to feel psychologically safe speaking up. And I think one of the things about gender equity. And, you know, it doesn't have to be so bold as those two examples that I just shared, but like, those have been things that I've not looked for. They've come to me and they've happened. I've been like, huh, that's interesting. I didn't know medicine was going to be like this. And that, you know, I think creating psychological safety for people to speak up, for people to share their experience, for people to sit in a room and be on a working group together to create solutions. But there's a lot of fear. And one more thing I'll say, and then we can see if there are some questions. Reshma and I have a lot of respect for her, and she's exquisitely published in this field. During COVID, I said, you know, can we write something together? So we have a piece in academic medicine about the gender discrimination curve. And now it's time to flatten the discrimination curve, because we were seeing a lot of women were doing the work, whereas and there was a lot of bullying, harassment, and aggressions being done towards people because of status anxiety. Women were going to get credit for the work they were doing. Perhaps they were going to be threatening the leadership position of some of the men. And we were talking about how we were hearing about this across different institutions. So, you know, it can be subtle, it can be not so subtle. But I think what I've learned as I've been in my own journey, learning the literature and speaking on this, is there's plenty of data to support this. And so it's not, is it happening? It's more, what can we do? And what can we do together? Because diverse teams are better teams.
Thank you very much for that. There's actually, it gave enough opportunity for individuals to actually post their questions. Here's one. Do you have any advice for how to handle situations where males are defensive? For example, in a division meeting, a male researcher got very defensive of the NIH gender funding rates and said, reviews are objective and the science from males investigators is just better. I tried to explain nicely about the systemic issues that might put women at a disadvantage, and it did not go well. Do you have any advice? And I am sorry, I will not reveal who made this comment, but I'm very sorry that you had that experience.
Yeah, so number one, I'll say thank you for sharing and thank you for posing the question, because again, if you had this experience, one thing I've learned is if I've had this experience, I'm not the only one. And there is a power in sharing these experiences because it makes people more comfortable speaking up, and it does raise awareness for those that aren't in the room to know that these things happen. And again, I think it raises awareness for leaders to be like, I had no idea that was said. So number one, my first response is like, wow, that is surprising that he didn't get the 411, the information that actually everything is not equitable. So I think there's a few ways to think about this. I am a reader and I love pointing people to books. There's a great book called Better Allies. And my two of my co-authors for that Stop Defending Good Guys are the co-authors of that book, David Smith and Brad Johnson. They wrote first book called Athena Rising. They wrote a second book called Good Guys. And the way it even came about is they came on the podcast. We talked about their book. And I said, after we recorded, I said, by the way, have you ever heard people flip the argument around 180 and use good guys rather than not truly talking about good people, but actually using it to defend? And they're like, we have, and it really upsets us. I said, do you want to write an article? So we wrote the article. So I think there is something very powerful when men talk to men. They will listen to it in a different way. So I think one thought is to have a man sort of speak to the group or be the one to educate the group on NIH funding and the history of NIH funding. I think, pulling the articles, pulling the literature to demonstrate, but maybe not send it to that individual, but just send it as information to the whole research group. And then I think if you trust your chair, and if you trust your leadership, I think bringing that to them so that the messaging comes from someone in leadership position, that can be more powerful and the message can be heard more broadly.
Thank you very much for that. That actually reminded me, our WIMS group a couple of years ago talked about the Feminist Fight Club and how Colorado State University was using the Feminist Fight Club as a way to have men join as allies and have their own development as upstanders in terms of gender equity. Let me allow Dr. Cindy Brown to speak. And Cindy will be the last question today. So Dr. Cindy Brown is one of the co-chairs of the Women in Medicine and Science group for the Department of Medicine, and I believe that she has a comment.
Sure. Thank you so much. This was fantastic. And it did strike me, the comment that we can't put the burden of change on those of us who are already, feeling this burden. And I would just like to point out it's even harder for our individuals who are underrepresented in medicine. And then when you have the intersection of being both a woman who is also underrepresented in medicine, it makes it even harder. So do you have advice for how do we engage men and allies? Is co-lead for our women's group, are there programs that we should be bringing to our men that want to be allies to help them in our work?
Thanks for the question, and thanks for restating the compounding effect of intersectionality. And I think first off, and I'll use the example of emergency medicine, what I've found is at, say, the main annual conferences, there'll be a main stage program and there'll be, quote, breakout groups. So I think one thing is to make sure that the discussion regarding equity is not the breakout group. It's not, sign up if you're interested, that it's actually made part of the main program and the main messaging and the main speaker series. And so that means, I think, speaking to conference organizers, speaking to workshop organizers. I think also, I believe these challenges are everywhere. There are some places where it is worse than others. There are some specialties where it is worse than others. Since they are everywhere, there are also allies everywhere. Are there a lot? No, I don't think there are a lot, unfortunately. However, hopefully that will change as we educate. So if we give people the benefit of the doubt that we are good people and we're trying to help have healthy, psychologically safe environments, I think education is a big piece. So I mentioned these books, Athena Rising and Good Guys by Brad Johnson and David Smith. There's another one by Karen Catlin called Better Allies. And actually she's writing right now the Better Allies Healthcare. So I think books, there can be mandatory reading. Now we are overwhelmed and the goal is not to pile more work on, but I think if there's a process of a regular journal club, it can be a regular journal club topic. The other thing is, I think it's sort of showing that it's going on in your own backyard. So as you know, I'm emergency medicine, I'm ultrasound, and I have everything that I talked about generally in emergency medicine, generally in medicine. I have noticed it in my own small microcosm of ultrasound. People say to me, Resa, there are no people of color in our community. I'm like, yes, there are. I'm like, did you, and, so all these things that people claim, like, well, we must write better research projects and that's why the men get it. No, that's not true. So we published a piece about the state of gender equity in the emergency ultrasound community and the state of racial ethnic inclusion in the emergency ultrasound community. So sort of, we're willing to look at, and it's like, there are 15 authors on the paper, men, white men and men of color, white women, women of color, and other sort of marginalized in medicine, underrepresented. But the goal was publication. And I guess I'll end by saying it took me a while to jump on the publication bandwagon. And certainly if you were to PubMed me, I have plenty of PubMed publications. What I emphasized today was talking a little bit about Slate Magazine and Harvard Business Review, because that has a broader audience. And because, again, what's happening in medicine is happening in other industries and it resonates. So that's to say that I think publishing is a currency. It is scary. It's scary, I think. And it's took a while to become comfortable publishing on these things, because if you've ever had retaliation, if you ever had negative consequences, like there's real reason, and you've seen it probably happen to colleagues. That being said, I think publishing is a very strong currency. Publish with people you trust and publish with people that may not be directly, or everybody thinks they're not affected. Why would they be interested? Those are exactly the people that need to put their name on a paper and participate in the writing of that paper.
Thank you very much, Dr. Lewis. I want to thank you for joining us today. This was amazing. I tried to keep up with all the references and citations, so hopefully the audience was able to click on some of those links, and that was very helpful. Thank you again, and hope to see you soon.
Yeah, thank you.
Maybe,
And
maybe at WMC.
that would be great. And I just want to say I welcome outreach on Twitter or through LinkedIn or through my website. And yeah, I really appreciate the opportunity. Thank you for thinking of me for this.
No problem. Have a great evening, everybody.